Hello, I am Dr. Neeraj Singh with the Northwell Health Neurosciences Institute in New York. I am pleased to present to the Unite Scientific Aging Conference on the association of early-onset dementia with Lewy bodies with atypical mutations. Today, I will be providing an overview of the condition dementia with Lewy bodies, or DLB, followed by an overview of two cases of young patients presenting with symptoms pointing to a neurological disorder. I will discuss key results from the tests done for each of these cases and the conclusions that we reached with these cases. First, an overview of DLB. DLB is the second most common neurodegenerative cause of dementia following Alzheimer's dementia. Population studies reveal that this condition affects 0.4% of the global population over the age of 65 and tends to affect men more often than women. Under pathological examination, eosinophilic inclusions are identified in neuron cell bodies, as seen on this slide marked with a blue arrow. These inclusions are termed Lewy bodies and contain aggregates of alpha-synuclein, making DLB a synucleinopathy. We will go over two cases, one of which involves a 42-year-old woman with new-onset physical symptoms without notable cognitive symptoms, and another of which involves a 43-year-old man with a known family history of dementia. In the first case, a 42-year-old woman presented with new visual hallucinations, head tremors, difficulty maintaining sleep, and intermittent muscle spasms affecting any of the four limbs at random times. She has a history of Hashimoto's thyroiditis, which was controlled with levothyroxine, as well as a benign cerebral meningioma without mass effect, and anxiety controlled on fluoxetine. There was a history of transient ischemic attack in the patient's mother, as well as stroke and hand tremors of uncertain etiology in the patient's father. She acknowledged occasional alcohol use, but denied binge drinking or any association of alcohol intake with worsening of symptoms. She also denied smoking and illicit drug use. Her blood tests were notable for elevated thyroid stimulating hormone and anti-thyroid peroxidase antibody levels, although with normal T3, free T4, and total T4 and anti-thyroid globulin levels consistent with controlled Hashimoto's thyroiditis. She also had borderline anti-nuclear antibody titer and low vitamin D level. Other blood test results were normal. In the second case, a 43-year-old man presented with a 3-year history of declining short-term memory and concentration, and over the following 2 years developed dysphagia, gait instability with frequent falls, loss of receptive and expressive language skills to the point that he had difficulty stating his own name, worsening behavioral disturbances including violent outbursts, and new-onset generalized convulsive seizures. He has a history of chronic paranoid schizophrenia that had been well controlled at the time that he started to show declines in his memory and concentration. He had a twin brother who was diagnosed with DLB in his mid-30s based on his clinical examination and who died at the age of 40. Multiple other family members were reported to have had early onset cognitive impairment, although the patient could not specify which relatives. He was a former smoker, but was not currently smoking, and has no history of alcohol or illicit drug use. His blood test results were normal. Now we will discuss notable additional results that helped confirm the patient's diagnoses. The patient in case 1 had a Montreal Cognitive Assessment, or MoCA, score within the normal range of 27 out of 30 on initial examination. She had a PET FDG CT scan of the brain, which revealed hypometabolism in bilateral parietal and occipital regions, as seen in yellow. There is preserved metabolism in the posterior cingulate gyrus, seen in red and circled in black, known as the cingulate island sign. These findings were re-demonstrated in the second image, which comes from a PET FDG MRI scan of the brain performed 14 months later. These metabolism patterns are highly specific for DLB. The patient in case 2 had a MoCA score of only 3 out of 30 on initial examination and subsequently could not participate in cognitive testing and follow-up appointments due to his significant cognitive impairment. His PET FDG CT brain scan, as shown below, in axial and coronal sections also showed bilateral parietal and occipital hypometabolism, as seen in yellow, with a preserved cingulate island sign, also seen in red and circled in black, and also consistent with DLB. Both patients underwent saliva swab testing for genetic panels for hereditary Parkinson's disease, hereditary amyotrophic lateral sclerosis, frontotemporal dementia, and Alzheimer's disease. The results for the patient case 1 revealed a heterozygous mutation in the PRKN gene, previously known as the PARK2 gene. This is known to be associated with early onset autosomal recessive Parkinson's disease. The results for the patient case 2 revealed a heterozygous mutation in the PSEN1 gene. This is known to be associated with early onset autosomal dominant Alzheimer's disease type 3 or AD3 and is correlated with autosomal dominant acne inversa type 3 or ACNINV3. We will now discuss the conclusions from these case reports. Regarding the management of these patients, the patient case 1 was started on rivastigmine, an acetylcholinesterase inhibitor that has been shown to slow down cognitive decline in DLB. She was initially started on an oral formulation, but due to gastrointestinal distress as an adverse effect, this was switched to a transdermal patch, now dosed at 9.5 mg per 24 hour, once daily. She continues to take levothyroxine, 50 micrograms daily, to manage Hashimoto's thyroiditis, as well as fluoxetine, 60 mg daily, to manage anxiety. Her visual hallucinations and muscle spasms have resolved, and she has fewer incidents of disturbed sleep. However, she continues to experience intermittent head tremors. The patient, case 2, has been started on rivastigmine, 4.5 mg by mouth twice daily. To manage chronic paranoid schizophrenia and behavioral disturbances associated with DLB, he has also been started on quetiapine, and this has been titrated to a high dose of 800 mg every night. He is also maintained on Depakote, 250 mg twice daily for seizure prophylaxis, which also helps with mood stabilization. Despite being on these medications, he has had significant cognitive decline over the past 3 years, and he is currently in a skilled nursing facility. Some things to consider for both cases. As mentioned before, the patient case 1 did not exhibit notable cognitive symptoms in her initial examination, but still had new unexplained symptoms that raised concern for a neurological etiology. She was seen by a dementia subspecialist who dismissed her symptoms as being related to anxiety, even though the patient's anxiety had been well controlled up until the point that she had developed these new symptoms and had not previously involved visual hallucinations or tremors. When asked to account for the patient's abnormal neuroimaging findings, the subspecialist stated, "I would not have obtained these studies in the first place." Despite this opinion, the patient was started on rivastigmine and has shown clinical improvement with her symptoms. Meanwhile, when the patient case 2 started to exhibit decline in memory and behavioral changes, they were attributed to his history of chronic paranoid schizophrenia, even though this had been controlled with medication for a few years up until that point. When his twin brother was diagnosed with DLB based on his clinical examination, he had a basic CT scan of the head, which revealed cerebral atrophy, but he was not offered PET FDG imaging or genetic testing before he passed away. Even though DLB has been reported to have an incidence over the age of 50, this is based on population data before widespread availability of PET FDG neuroimaging and genetic screening, and may be outdated. It is possible that younger patients may start showing signs of DLB or other forms of dementia even earlier than age 50, especially if there is a genetic component. Early signs of cognitive impairment or dementia should be taken seriously and appropriately worked up, and not dismissed or attributed to other conditions as they initially were in these cases, especially if the other conditions have been well controlled or if new and different symptoms appear. Our knowledge of genetic mutation associations with DLB and other forms of dementia may also be incomplete, as evidenced by the presence of 2 mutations presented in these cases that have no known association with DLB, despite the clinical and neuroimaging findings for these patients consistent with DLB. These results also raise additional questions. For example, does the patient case 1 with the PRKN mutation actually have a form of hereditary Parkinson's disease? Or does she have a syndrome that has not yet been described that involves the PRKN mutation and a phenotype similar to a mild form of DLB without cognitive symptoms? Also, does the patient case 2 have coexisting Alzheimer's dementia attributable to the PSEN1 mutation, or does a PSEN1 mutation actually have a potential association with DLB instead of only with Alzheimer's dementia? The genetic studies for both patients are limited also by the fact that whole exome sequencing for the GBA gene was not available for either of them, even though GBA mutations have been reported to exist in DLB. These findings show that more research is needed into the full complement of associations of these genetic mutations with different phenotypes in patients with dementia. In summary, we should be mindful to take concerns for cognitive and other neurological symptoms from young and middle-aged adult patients seriously so that we can determine whether they may have an early or mild form of dementia that can benefit the most from currently available treatment. By showing this respect and comprehensive care, we may come to find that these neurodegenerative conditions are more widespread and have more genetic mutation associations than we initially thought. Here are the references used for background research for this presentation. Thank you all for your time. I hope you found these cases and this topic interesting, and please reach out with your questions.